Good evening, everyone. My name is Melanie Ionase. I'm a physician relations specialist here at Rothman. Tonight's webinar is with Dr. Barrett Woods, spine surgeon here at Rothman. Office locations are Egg Harbor Township, Washington Township, and Manahawkin. Topic that he'll be covering this evening is spinal surgery right for you. This will be an insightful virtual discussion focused on the diagnosis and treatment of common spinal disorders. Learn about the latest techniques in spinal care, treatment options, and expert tips to help guide your health decisions. We hope you gain valuable knowledge from a seasoned expert and empower yourself with informed choices for optimal health. Just a few quick notes. At the bottom of your screen, you will see a Q&A icon, so feel free to ask questions throughout the webinar, and we will get to as many as we can at the end. Also in the chat box, I will share Rothman's phone number if you would like to make an appointment, as well as my information for any assistance you may need. This webinar is being recorded and will be emailed to you within 5 to 7 days. So without further delay, I will pass this off to Dr. Woods. And Dr. Woods, thank you for joining us this evening.
Pleasure. Thank you, Melanie, for that introduction. Hello, everybody. Welcome. My name is Barrett Woods. I'm a spine surgeon at Rothman Institute. It's amazing. It's been 9 years now I've been here, so time is flying by. It's going quickly. But I just wanted to participate in this webinar to, first of all, provide some information and some education about what spine surgery does and what it does not do. And then you can make the decision as to if you want to be formally evaluated or not. But there's a lot of misconceptions about spine surgery, a lot of fear about spine surgery. So hopefully this can provide some insight into regards to what spinal surgery does well, what it does not do well and hopefully that can help guide you moving forward. So I'm originally from Pittsburgh, Pennsylvania. I did my medical school and orthopedic surgery residency there in University of Pittsburgh, and I did a joint neurosurgery and orthopedic spinal surgery fellowship at Thomas Jefferson. I had every intention of going back to Pittsburgh. My wife did not. So my wife is a physiatrist. She wanted to leave Pittsburgh. And so we ultimately ended up taking a job at Rothman Institute. And it's been 9 years now. We've been here. So I work in Washington Township. I work in Egg Harbor Township, and I will be working in Manahawkin as well, and operate at two hospitals, mainly Atlantic City Medical Center, as well as Thomas Jefferson University. And my practice revolves specifically around spinal surgery. That's all I do is spinal surgery. And there's different facets of spinal surgery I do. The most common is people who develop degenerative conditions over time, so arthritis or disc herniations leading to nerve impingement. But I also do some surgery on folks with scoliosis, tumor, and definitely do a lot of spinal trauma. Unfortunately, that happens quite frequently in Atlantic City. So I can tell you one of the most humbling things about spinal surgery for me is it really is incredibly gratifying to take care of people. I don't know what raises folks' blood pressure more than the prospect of spinal surgery. I mean, when I tell folks that they need surgery, oftentimes they'll bust out crying. You can just palpably feel and see the fear. And, it's understandable. Everyone has an anecdotal experience, knows somebody who had a spinal operation that they did not do well. And so the prospect of getting an operation on the spine just seems like such a daunting task, it's such a roll of the dice. Will you ever be the same again? Will you be paralyzed? And so I certainly understand that fear. And so it's very humbling and gratifying for me when I see people come in and they have such trepidation and such fear about these operations. And then they come back after the surgery is done and they can't believe how good they are, how much better they are. And so the whole purpose of this is to let you know, like, spinal surgery is pretty predictable. The outcomes are pretty predictable. It may not seem like that to you, but when we get on a plane, we expect the plane to land. American Airlines expect to get to your destination. And I would tell you, in the hands of an experienced pilot, that's going to happen 99.9% of the time. And the same thing is with spinal surgery. If you are seen by a spinal surgeon at Rothman Institute, your surgery is indicated, and you have the procedure, more likely than not, you will improve. There are certain things that spinal surgery absolutely gets better, and there are certain things that spinal surgery does not. And it is hard sometimes because there are a lot of people that come in and see me and they're in terrible pain, and I tell them surgery is not going to help them. And that's not because I don't believe they're in pain. It's just that I know that there are things that surgery fixes well, and there's things that surgery do not fix well. And so that's why I can tell you that if I tell you you need an operation, it's that your outcome is very predictable. This is not a roll of the dice. And so we were going to kind of go through some common things to just get you to educate you, talk a little bit about spinal anatomy, which I think is really cool. And one of the reasons I fell in love with spinal surgery. We'll talk about some of the common issues or pathologies or problems that I see with cervical and lumbar spinal issues. And then we'll talk about some of the advancements, some of these advancements that have changed since I trained, in my training in 2013. Even since then, we do a lot of things better over the past 10 years than we did a decade ago. And that has facilitated patients' recovery and kind of hastened their recovery and decreased their risk for complications and things like that. So we'll get into all those things. So when I was a student, a medical student, I worked in a laboratory at University of Pittsburgh, and we focused on the intervertebral disc. So the intervertebral disc is a pretty interesting structure. It is the largest avascular structure in the body. So what that means is there's no direct blood supply to the disc. And the disc itself has an outer ring, a fibrous ring called the annulus, and an inner jelly portion called the nucleus. And that nucleus sucks in water and serves as the shock absorber for the spine. And the vast majority of the issues that we experience with our spines is because of degeneration of the disc. That could lead to herniations of the disc, compressing nerves. It can lead to the development of arthritis in the spine, compressing nerves. But the vast majority of the problems we have come from the disc not doing its job, not serving as the shock absorber that it was designed to be. And so when I was in this laboratory, we were looking at these animal models, and we had a model in which we could degenerate disc in rabbit, and we were injecting stem cells and gene therapy and all these things to try to see if we could reverse disc degeneration. We were giving them glucosamine and chondroitin, and I can't tell you how many numbers of studies we've done on these rabbits. And just unfortunately, at this time, we do not have the ability to slow or stop disc degeneration. It's something that we will all experience through our lifetimes. We know for sure there are certain things that accelerate it, like smoking, makes disc degeneration worse. And there's a genetic predisposition to disc degeneration, meaning some people just get it much worse than others. But it's the unfortunate reality of life is that all of us, as we age, our disc will degenerate. And so this is kind of a schematic kind of illustrating a plump and healthy disc here on the left. As the disc starts to dry out, it starts to lose its shock absorbing capability. And it progresses to the point that the bones start to bump together, the disc collapses, and you develop bone spurs. And so a very, similar analogy is that of a tire, right? So if you have a healthy tire, the rim is protected, tire goes flat, you start to bend the rim. And if you keep rolling, that rim will get beat up pretty badly. So the same thing that happens to tires in our back happens to our disc. And the more miles you have on you, the more likely you are to have some degeneration. So this again is an example of healthy discs. So a healthy disc is plump and juicy. And as discs degenerate, they start to become fibrotic and dry. And when they become fibrotic, the bones bump together, and that can lead to arthritis. Everyone gets disc degeneration. Disc degeneration in and of itself is not a reason to have a procedure done on your back. We will get into surgical indications why we do surgery. But disc degeneration in and of itself is not a good reason. Typically, surgery is reserved for people who have degenerative changes which lead to compression of nerves. Compression of nerves can result in pain, numbness, or weakness in the arms or legs. And that's when we consider surgery, not disc degeneration itself. But the degeneration of the disc is typically the foundational problem. That is, in most folks, what started the problem. People ask, how did I get here, doc? It was probably because of degeneration of the disc, which led to herniations or arthritis, which compress nerves. In the cervical spine is pretty cool anatomy in that Your brain is connected to your body through your spinal cord. So your spinal cord is your information highway between your brain and your body. So this is an MRI looking at the person from the side, and this is the cerebellum or the brain. The brain stem becomes the spinal cord. So the spinal cord transmits signals from the brain to the body, and also takes information back to the brain. So when you touch and feel, and that information is received externally and sent back to your brain through your spinal cord. So it's an incredibly cool organ. And the spinal cord itself typically starts at the base of the skull and ends at the bottom of the thoracic spine. At every level in the neck, you have nerve roots which exit the spinal column. And each one of those nerve roots supply a specific portion of your arm, strength and sensation to your arm. And so people come in to see me and they have pain shooting down their arm. And I'm already thinking in my brain, where would their disc herniation have to be to cause those symptoms? Because we literally are mapped. Our bodies are mapped out, and these nerves supply specific portions of our arm. C5 nerve root is the deltoid, C6 is the biceps and the forearm down to your thumb and index. C7 is typically your triceps down to your middle finger, and your C8 nerve root is your hand intrinsic function. And so people that have disc herniations in the neck that are symptomatic, typically that will result in severe pain down their arms. In the lumbar spine, the spinal cord typically ends, right? So most of the time, the lumbar spine, the spinal cord has stopped. And this person, the bottom of the spinal cord is at L2. That's called the conus, or the bottom of the spinal cord. And where that conus can end is variable. It can range from T12 to all the way down to L3. From the base of that spinal cord or conus comes the lumbar nerve roots, and it's called the cauda equina, or it's supposed to simulate a horse's tail because all the nerves are coming sprouting from the bottom of that spinal cord. And as in the arms, the lumbar nerve roots supply strength and sensation to specific portions of your leg. So my own mother, who I was very close with, she passed last year. It was very hard. I'm the firstborn son. My mom took care of me my whole life. When I was in medical school, she saw me spending countless hours studying. She washed, she took care of me. And she would come up and I'd be studying in the middle of the night. She'd see me in my books and bring me something to eat. And so she saw how hard I worked. And she had an L4 radiculopathy, which means there was a compression of a nerve in her back. And she was having pain radiating down her leg to her knee. And I told her, Mom, this is in your back. And she was convinced, adamant that it was her knee, that it was not her back, that it was her knee, because she had no pain in her back. And I say this to say my mom, who sees how hard I'm working, knows how much I'm studying, did not believe me. And oftentimes people can't believe that the pain that's in their legs is coming from their back. But it certainly can be. The nerves that are in the back supply strength and sensation to the legs. And so this is a lumbar dermatomal chart. As we talked about the cervical spine, lumbar dermatomes, your L1, L2 nerve roots supply your groin. L3 is the front of your thighs. L4 radiates over your knee to the medial shin. L5 is the side of the leg. S1 is the butt, the back of the thigh, the calf to the lateral border of the foot. Sciatica is a term which is thrown around all the time. But true sciatica would imply that your S1 nerve root is compressed. So if you have compression of your S1 nerve root, that would cause pain down your butt, back of your thigh, your calf, to the lateral border of your foot. If any other nerve root in your back is compressed, L1, L2, L3, L4, L5, that will cause pain in a different distribution in your leg. And the medical term for that is called radiculopathy. And so those may be terms that you may hear. But sciatica, people come in all the time and say, Doc, I got sciatica. I got terrible pain in my back and in my butt. That's not really sciatica. Sciatica would have to follow the S1 distribution, which is down the back of your leg, calf, lateral border of your foot. So what are some of the common problems that I see in the office, and people come to see me all the time? We'll talk about neck pain. We'll talk about disc herniations. What is stenosis? What is myelopathy? What is radiculopathy? These are all very common cervical problems that I encounter. Very commonly, we see people with neck pain. So neck pain is multifactorial. The most common cause for neck pain is inflammation of the muscles in the neck that support the head. but can also be due to the development of arthritis in the facet joints. The facet joints are what this back arrow is pointed to. This line right here is the facet joints. And so if you develop arthritis in the facet joints, that can cause axial neck pain as well. This is an example of anterior osteophytes or bone spurs. So what has happened is this disc has degenerated. Because the disc has degenerated, the bones bump together, bone spurs are formed anteriorly. And so oftentimes people see that and that's quite alarming, but this to me is not too concerning. Just because you have anterior osteophytes, not really that big of a deal. The real concern is when you have bone spurs going into your spinal canal, compressing your nerve roots or your spinal cord. That's much more concerning than anterior osteophytes, which are very common. Again, the most common cause of pain is muscular. The trapezial muscle starts behind your ear and starts on your scapula into the midline. And that muscle is always working to keep your head upright. And when that becomes inflamed, it can cause a tremendous amount of pain. The facet joints themselves, so the facet joints can cause referred pain. So each facet joint, this kind of illustrates kind of the areas that those facet joints map out. So if you have arthritis of the facet joint, almost like a hip or a knee, it can cause a lot of neck pain, crepitus, limited range of motion. And so I would say people that come to see me all the time have terrible neck pain. And neck pain in and of itself is usually not a very good reason to have surgery. Your neck pain could be severe, but if you have predominantly neck pain, more likely than not, I'm going to tell you do not have an operation because surgery is not designed to treat and does not typically improve neck pain. If the neck pain is muscular in origin, there are interventional procedures that can be done, like acupuncture and trigger point injections to help. The foundational thing, which improves muscular neck pain, is physical therapy. That often irritates people because we all know therapy is not easy. You do therapy for a short period of time, you're not better. But there's no question that physical therapy to strengthen the muscles in the neck is the best treatment for muscular neck pain. If you have facet-mediated neck pain, so facet-mediated neck pain, meaning you have arthritis of the facet joints. We do injections into the facet joints themselves, and that temporarily alleviates your pain. That's when we would consider a ablation procedure. So people hear radiofrequency ablation. A radiofrequency ablation is a procedure that numbs the arthritic facet joints in your neck, can also be done in the lower back. That's done by the pain management doctors. And that is appropriate if you have arthritis in your neck, you have neck pain, you have diagnostic injections into the facet joints, which give you temporary improvement in that pain. That's when you would do an ablation procedure or radiofrequency, RFA is what it's called. But neck pain or back pain is the same thing. Typically, we do not do surgery for neck pain or back pain. This is typically treated without surgery. Some of the things we do surgery for is if you have stenosis resulting in spinal cord compression. So stenosis is another term that's very commonly thrown around, but essentially all that means is that the space for your spinal canal, your spinal cord, and your nerves is being narrowed. And that can be narrowed by a whole number of different things. It can either be from a disc, which is herniated. It can be from hypertrophy of the ligaments in the back of your neck or your back. It can be from bone spurs. It can be because your alignment is messed up. But stenosis just means that the space for the spinal canal is narrowed, and that can result in compression of your spinal cord or your nerves in your neck. When we're assessing someone's neck, alignment of the neck is important. You should have a normal lordotic alignment, which is a reverse C alignment. And so in the middle, this is someone who's lost their normal alignment. And this is an extreme case, which is called kyphosis, when the neck is going in the wrong direction. And so when people have abnormal alignment, that has to be taken into consideration if we are planning surgical reconstruction to remove compression from spinal cord or nerves. But we consider an operation on the neck if you have spinal cord compression. So you have stenosis in your neck and your spinal cord is compressed. How that typically presents, if the spinal cord is compressed, remember that's the information highway between the brain and the body. Brain and the body is that can affect your balance, that can affect your strength or your manual dexterity. Typically, people will present with subtle losses of function. You can't button buttons well. You can't button your bra. Your handwriting is changing. When you walk, you feel off balance. Those can all be signs of spinal cord compression. And if you have spinal cord compression, we typically will do an operation to remove that pressure from your spinal cord to prevent you from getting worse or losing more function. So we talked about indication. One of the reasons that I would consider recommending an operation to someone is if they present with compression of their spinal cord and they have some of these symptoms, problems with balance, problems with dexterity or strength. Now, there are people that have these problems with balance, problems with dexterity, problems with strength. And then you get an MRI of the neck and the spinal cord is not actively being compressed. If the spinal cord is not actively being compressed, you do not have surgery. And so you need symptoms and you need compression in order for an operation to be considered. And so this is an MRI which shows severe spinal cord compression. Here, you can see the spinal cord, you can see the white lubricating fluid and these huge disc herniations here at C3-4, C4-5. There's severe compression of the spinal cord. Down here, it's pretty normal. This is an example where the spinal cord compression is not as severe. This person's alignment of their neck isn't great. They do have disc herniations here. But if you look at that spinal cord, I can follow that spinal cord all the way up and down, and there's not really severe spinal cord compression. So for me to recommend an operation on your neck for myelopathy would mean your spinal cord is compressed and you have issues with balance and dexterity, strength. You need compression of the spinal cord on MRI. You need physical exam findings which correlate with that, and you need to have these type of symptoms. And most of the time, people that have spinal cord compression, we do surgery. The whole purpose of these operations is to preserve function, to prevent you from getting worse. Oftentimes, people do get better as far as regaining strength and balance and coordination. And there are many factors that go into that. These operations are not fixing the spinal cord. They are removing pressure from the spinal cord. And then hopefully the spinal cord can breathe and heal. People who smoke, people who are poorly controlled diabetics, people who are immunocompromised or have other issues that would prevent the spinal cord from healing are not going to regain as much function as people who are healthy and normal. The other thing that can affect someone's recovery is how long this has been going on for. If your spinal cord has been compressed for 15 years and you've been slowly getting worse for 15 years, the likelihood you regain all your function is lower than someone who had an acute change over a month or so. But that is myelopathy, that is spinal cord compression. This is an example of a person who was myelopathic. So this was a 47-year-old woman. If you look at her x-ray, she had some degeneration of her disc, some anterior osteophytes. No big deal on her x-ray. But when she came in, she had a lot of weakness in her biceps. She had some pain down her arm. And the biggest thing she had noticed is she was losing the ability to button her bra. She felt very clumsy with her hands. And so this is an MRI of her neck. You can see her spinal cord right here at C5-6 is being dented in. And this is the cross-sectional picture showing this big disc herniation. It's compressing her spinal cord. Her spinal cord looks like a jelly bean here. This right here is the C6 nerve root. On the right side, it's being compressed very severely. So this is a woman that has problems with balance and strength. She has weakness in her arm and severe pain shooting down her arm. She also has lost some dexterity in her hand. This is someone who needs an operation, particularly seeing the severity of her spinal cord compression. And so I did a single level fusion on her, an anterior cervical discectomy infusion to remove the pressure from her spinal cord and the pressure from her nerves. That's a 30-minute operation. It was done as an outpatient, come in the morning, go home the same day, and she regained her function, her arm pain improved. Now, a lot of people ask me about fusion versus non-fusion options. This woman required a fusion because she had arthritis, so her disc had collapsed and she had anterior osteophytes. If she did not have that, we may have considered a disc replacement, so if there was no arthritis. And the analogy I give people is if you have a bent rim, you're not going to just change the tire, right? If the rim is normal, you can just put a new tire on the rim and it's fine. But if the rim is bent, you got to change everything. You got to fuse it. And so if you have arthritis, a disc replacement is typically not a good idea. If you do not have arthritis but have compression of your spinal cord or nerves, then that's when we consider a disc replacement. A single level fusion or even a multi-level cervical fusion is not going to affect the motion in the neck. One of the concerns with these fusion procedures is the development of what's called adjacent segment degeneration. So you can develop arthritis above or below where the levels are fixed. And that happens in about 20% of people will require another surgery down the line. But the goal with these procedures is less is more. We typically will only fuse the segments in which there's crushing. If you develop arthritis above or below and it becomes symptomatic, we treat it. But that's, 2 in 10 people require another operation typically after a cervical fusion. This is another example, a little bit of a different scenario. So this was an older gentleman. He came in and he had profound numbness in his arms, tingling and pain radiating down his arms, and he was very unsteady on his feet. His balance was terrible. And so I got this MRI of his neck, and he has congenital stenosis, meaning his spinal canal. He was born with this narrow at baseline, and then he developed cord compression throughout that. So if you look at the bottom here of this MRI, you can see the spinal cord, you can see the fluid on either side. And then here, throughout here, his spinal cord is being crunched. And so he has problems walking, he has problems with his strength and balance, he's dropping things, and he has multi-level spinal cord compression. This gentleman needs an operation on his neck. And so we did a laminoplasty, an operation, you go in the back of the neck to open up that spinal canal. So you can see the before and after MRI in which his spinal cord now can breathe. And then he was able to regain some function. He still had numbness in his hands. He was not perfect, but he was much better. He went from walking with a walker to really walking without anything over time. And so that's the power and benefit of these operations, that if the issue is addressed in a timely manner, you can regain and preserve some function. And so this operation is a cool surgery that we can occasionally do. It's a non-fusion option, and the whole purpose is to hinge open the spinal canal. So you hinge open the canal, and this plate is placed, and that opens up space for the spinal cord. So this is the intraoperative picture. You can see this plate here. Underneath here is the spinal cord. And so by hinging open up that spinal canal, that spinal cord can now breathe. And this is an alternative to fusion that we can occasionally do in people who have normal alignment in their spine, not a lot of arthritis. It's typically a little bit easier of a recovery than doing a cervical fusion, particularly a posterior cervical fusion. So if there is an option to preserve the motion and not to fuse the segments, we will do that. But even with a cervical fusion, there's this connotation that people are going to lose the ability to turn their head. I've done multiple level fusions on folks. You wouldn't know their neck was fused because most of your motion, flexion, extension, and rotation comes from up here. So from the occiput C1 level and from the C1, C2 level. So even though this woman has all this fusion in her neck, she could still turn her head. You wouldn't know that her neck was fused. Now, if you have to fuse these segments up here, that's when the motion really, really gets restricted. So if you have to fuse C1, C2, that really will affect your rotation. Occiput C1, that will really affect flexion extension. But even with a cervical fusion, you really can still turn your head. The concern with the fusion procedures is development of arthritis above or below. And that risk is much less if you do a motion preservation operation like a laminoplasty or a disc replacement, which we'll talk about. So those were two examples of myelopathy: spinal cord compression, resulting in problems with balance, dexterity, and strength. Cervical radiculopathy would imply a nerve in the neck is pinched. And so people that have nerve impingement come in with terrible pain shooting down their arms. And the vast majority of these people we can treat with injections and physical therapy. People who have persistent arm pain or weakness, we do an operation. This is just a example of foraminal stenosis. So this is the spinal cord right here. This line right here is the nerve root. And so this is a bone spur, uncovertebral hypertrophy or bone spur, which is pinching the nerve in the neck. So if you have compression of a nerve in your neck, it can cause searing, severe pain down the arm. And oftentimes we treat those people without surgery. The patients that require surgery, these are some of the happiest people because literally when they wake their eyes up from recovery after the surgery is done, their pain is better. Arm pain typically is alleviated almost immediately in most people. And I can't tell you how many people I've come to see. Literally, they're awaking from anesthesia, and the first thing they say is, "Oh my God, my arm pain is better." And so that's pretty gratifying. And people do get pretty instantaneous improvement with these surgeries if they have compression of a nerve, they have pain in the distribution of that nerve. Those are folks that surgery really typically does help. So this is an example. This person came in. This was, I think this woman was about 50. She had a normal alignment of her neck, no arthritis of her neck, no bone spurs. She had terrible arm pain and weakness in her arm. And so this is a normal kind of cross section showing the spinal cord as well as the nerve roots. And she had one that we considered doing an operation, and I did an operation on her because not just the severity of her pain, but the weakness in her arm. And she had a disc replacement because she did not have any arthritis. So this is also another operation which is done as an outpatient. People come in, we do the surgery, they go home the same day, and her arm pain when she woke up was better. And you can see the difference here. This is literally an artificial disc that goes into the disc space as opposed to a fusion with plate and cage. So we talked about lumbar cervical issues, neck pain. We don't do surgery for neck pain. Neck pain is either muscular or it's from the facet joints typically. If you have facet mediated pain, that's when we consider radiofrequency ablation. Myelopathy, spinal cord compression, that affects your balance and your strength. Radiculopathy is nerve root compression, that causes pain down the arms. Now we'll talk about common back problems. So back pain, everyone's had back pain and it can be bad. Talk about lumbar disc herniations and when it's a problem, spinal stenosis or narrowing of the spinal canal. Spondylolisthesis is a translation or slippage of the vertebrae. And then there's people that have scoliotic curves, and we'll discuss that. But I had a person the other day who said, Doc, I have terrible back pain and every disc in my back was herniated. And I looked at their MRI and they did have some disc herniations, but they weren't severe. So what does that mean? Remember, the disc is the jelly donut. This is a lumbar MRI here. And if you look right here at L3-4, this is a disc herniation right here. So this is a disc bulge. This disc bulge is not that severe. I can still see plenty of space for the nerves in the back. Contrast that to this right here. That's a huge disc herniation. That is compressing the nerves in the back. This person presented with severe pain shooting down their leg. So not all disc herniations are created equal. Disc herniations are concerning when they result in compression of the nerves in the back and the person has pain shooting down their legs. Back pain, as with the neck, most commonly is muscular. If someone has back pain, the first thing you think is it's their posterior chain, their muscles in their back. And again, those muscles are very powerful. They're always working to hold you upright. When they become inflamed, it can be very, very painful. Back pain usually is not a good reason to have surgery. So I have people that come in and have terrible back pain, and they may have multiple disc herniations, and they may have compression of their nerves. But I ask them, what is the biggest problem you have? What hurts you more than anything? They say, oh my God, Doc, my back. Those are people that I typically will say do not have surgery, do not have an operation, because back pain usually does not get better with surgery unless there's some mechanical issue. And we'll talk about that. But usually if you have back pain, we're going to try to treat you non-operatively. Muscular problems are the biggest issue. You can develop arthritis in the facet joint. So that's what this example is. These are the facet joints here, and this is arthritis of those joints. As in the neck, if you have facet arthritis and back pain, we can target those facet joints with targeted steroid injections. If that helps your pain and it only lasts for a short period of time, that's when we consider radiofrequency ablation. This picture in the middle is an example of disc degeneration. So we talked about the disc losing its ability to kind of shock absorb, and the disc can start to dry out. So you can see this disc right here is black. These discs are hydrated or white. So very frequently I'll see people that have some degree of disc degeneration, and they come in with back pain. These are folks typically, I would say, do not have surgery. Surgery does not predictably improve back pain, usually. Surgery very predictably improves nerve pain. So nerve pain would be shooting pain down the legs or down the arms. If you have that, an operation is going to help you. Back pain is not as predictable, the response. And so I have a lot of folks that come in and see me and they're in terrible pain, and I have to tell them, don't have an operation. And not everyone's happy with that response. But the reason I say that is if I tell you you need an operation, what I'm saying to you is that you are more likely than not to get better if I do your surgery. With back pain, the surgery can be done perfectly and you can still have the pain. If it's nerve impingement, the results are much more predictable. Some of the circumstances we consider doing surgery for back pain is if you have a spondylolisthesis. So this is an example of a big slippage of the vertebrae. There's a mechanical instability in your back and the bones are slipping that can cause back pain. And that's one of the circumstances which we will consider doing a fusion to stabilize those bones. That provides a solid base so that the pain can improve. And so there are instances in which we will do surgery with back pain being the predominant complaint. But this is an important thing for you guys to think about. And if you ask yourself, what is the thing that hurts me the most? And if it's neck pain or back pain, typically surgery is not the right answer. That doesn't mean you shouldn't be evaluated. You should be evaluated to make sure that you don't have instability or something else going on. But for most people, I would advise against surgery for those indications. There's people that come in with these scoliotic curves. You see this curve here and have back pain. Again, I can put rods and screws in your back to straighten out your spine, but you still may have back pain because it's muscular imbalance and those sorts of things. So back pain in of itself, beat that in the head. That is typically not a good reason to have surgery. There are some reasons that we would do surgery for back pain, or something called ankylosing spondylitis, in which your whole spine gets fused. And if you have a fall or trauma, your spine can become unstable. I've seen that happen. This is an example of that right here, of the spine translating. So patients with ankylosing spondylitis that have a lot of back pain, we image them to make sure that they don't have microfractures. And then those are people we would consider doing surgery on. But aside from that, pure back pain, typically avoid an operation. So why do we do surgery on the back? Nerve compression. If you have compression of a nerve in your back and you have pain down your leg, and that pain correlates with the nerve compressed, a back operation is going to help you. You will feel better. You will walk better. Your leg pain will get better. Instability in the spine. If you have pathologic motion, our spines are designed to move. But if the bones are slipping, the ice cream is falling off the scoop, that's when we may consider doing an operation on the back. This is an example of a spondylolisthesis, or a translation of the vertebrae in the back. You can see how this bone is slipped. Bone's almost at the 50-yard line. This is someone who would need an operation, a fusion operation, to stabilize those bones. People hear fusion and it has a negative connotation, but the analogy I give to folks is if your bones are slipping in your back, it's just like breaking your forearm. If you break your forearm, we put you in a cast that stabilizes the bones so the bones will heal together. It's the same thing in your back. If your bones are slipping back and forth, the rods and screws are going to serve as an internal cast or internal brace to stabilize those bones. The bones can then heal together. And so a fusion is just an internal cast to hold the bones together until they heal. And then there are certain circumstances in which people have curves that result in compression of nerves. They can't stand upright, where we may consider doing an operation to straighten out their spines. Operation on the back is for trauma. I see a lot of trauma patients, motor vehicle accidents, people falling off of things. And this is an example of a burst fracture. A burst fracture is when the posterior cortex of the bone, so the bone looks like a square, the posterior cortex is disrupted. So here, these bone fragments are pushed into the spinal canal. That needs to be differentiated from a compression fracture. A compression fracture typically happens in older women, most commonly. Women go through menopause, you don't make estrogen, your bones get soft, and the bones start to crumple. And with compression fractures, the bone almost looks like a bow tie because the middle is depressed, but the posterior cortex is intact, or a wedge, like a triangle. Compression fractures are treated with medications to strengthen your bones and therapy to strengthen your bones. You do not get surgery for compression fractures. Burst fractures, if it's resulting in compression of the nerves or instability of the spinal column, we would consider doing an operation. And that's typically in the traumatic setting. So people are in the hospital, they fell, they're in a motor vehicle accident. I would come in and stabilize their spine. And then this is an example of a deformity. So a lot of people come in and have a curve in their back, and I tell them no surgery. The circumstances I would consider doing an operation for them is if the spine is collapsed, like here on this side, and the nerve that's exiting is being pinched, and that causes pain shooting down their legs. Then, in those circumstances, an operation to straighten out the spine, to open up the space for the nerves would make sense because it's going to improve their leg pain, their ability to stand and walk. Just like in the neck, a disc herniation in the lower back is going to cause pain down the leg. So this is an example of a disc herniation. So this person has an extruded disc fragment. This is the L5-S1 segment. So this is compression of the S1 nerve root. If you look on the right side, you can see these dots here. That's the S1 nerve root. Here on this side, that's where the herniation is. You can't see the nerve. This is true sciatica. So the person presented with severe pain shooting down the butt, back of the thigh, calf, lateral border of the foot, could not stand on the tippy toes. So this is someone who needs an operation. Nerve compression, pain down the leg, which correlates, weakness, and operation is going to help them. And so I took them for a microdiscectomy. So a microdiscectomy is a minimally invasive surgery in which you have to make an incision, you have to make a little window in the bone, you have to pull out the disc fragment. So this is not a fusion, there's no instrumentation that goes in, but this is for circumstances in which you have a herniation, there's no instability, there's nerve compression and leg pain. You can remove those disc fragments. Just like in the neck, people typically wake up from these operations and can't believe the leg pain is gone. And it's gratifying because you can really help people. And sometimes the leg pain can be very, very intense. People can develop foot drops because nerves are pinched in their back. And so these are the circumstances in an hour, and typically is done as an outpatient. One of the improvements that we have in surgery is the ability to do these operations minimally invasively. When I was learning to do these operations 15 years ago, you had to open the whole back up in order to do it. And now we can do it through much smaller incisions, much less disruption of your muscles and skin, but still can get down to the nerves and remove pressure. And so the same surgeries can be accomplished through much smaller windows with lower recovery. And that's definitely an advancement in surgical technique. This is an example of a minimally invasive fusion I did. This is what this picture kind of shows you what you're looking at, but this is the nerve root here. There was a big cyst which was compressing that nerve. So this person had terrible leg pain. The cyst has been removed. You can see the nerve right here. This is the disc space. So that allows me the disc. I can remove the disc and place a cage to stabilize the spine. And we can do these operations minimally invasively. Again, this was a surgery done because the person had nerve impingement, couldn't walk because of pain down the leg. This is a home run operation. Do this surgery, you are predictably going to get better. So this is the x-rays to show you what was going on. So this person had a spondylolisthesis. So what this x-ray is illustrating is the level above at L4-5. The green circle is the neuroforamen. That's where the nerve exits the spine. The arrow is the disc space. You can see how plump that disc space is. At L5-S1, the disc is collapsed. The disc is gone. The arrow in the back is pointing to what's called a pars defect. There is a crack or a defect in the pars which resulted in the bone slipping. Look at the foramen down here. The foramen is much, much smaller. So that nerve is being pinched because those bones have shifted. And so this is the MRI of the back. And you look at the MRI, the spinal canal looks pretty open. The problem is nerve impingement. Their L5 nerve root is being crunched. So this person came in with some back pain, but terrible pain shooting down the side of his leg. Couldn't stand or walk, had to sit down, could only walk short distances. So he had a minimally invasive fusion. So I took out the disc, I placed the cage. The whole purpose of that was open up that foramen to remove that pressure from the nerves, place rods and screws to stabilize the bones. This person went back to complete normal activity, resolution of the leg pain. They still had some back pain, which was intermittent. I wouldn't say all their back pain went away, but the leg pain definitely went away, and he was able to walk and kind of resume normal activities. This is an example of an asymmetric disc collapse. So this woman came in, she had terrible burning pain down her left anterior thigh. And if you look at her spine is collapsing. So what that yellow arrow is showing is that osteophyte on the side of her spine is because her spine is collapsing. And when we got the MRI, her MRI shows that her L3 nerve root on the left side is being pinched. The L3 nerve root supplies the front of her thigh. On the right side, you can see the nerve here is not compressed. So why did we do this operation? This woman couldn't walk because of pain shooting down her leg. She had compression of her L3 nerve root, and her symptoms all correlated. So this is a perfect surgical candidate. Nerve impingement, leg pain, can't ambulate. Surgery is going to help her. And again, the whole purpose of this operation is to remove pressure from her nerve. So this was done through a minimally invasive lateral interbody fusion. So I went in from the side of her spine. I removed the diseased disc and placed a cage, and that cage opened up the space for her nerve. Then we had to place rods and screws in the back to stabilize the bone. So now we've straightened out her spine. We've removed pressure from her nerve. Her leg pain went away. She was able to walk. She got rid of the walker. Her recovery was about 6 weeks or so, one night in the hospital. And so these surgeries can be very, very effective, life-changing for people who have nerve impingement and leg pain. Now, if this same woman would have came to see me with this same MRI and this same nerve impingement, but her predominant complaint was pain in her back, I would have told her, do not have a surgery, because we are not operating on people's MRI. You have to have an MRI, which shows a problem, and your symptoms have to match up. And it's only then, if those things work and match up, will I tell you surgery will help you. So it's not just your MRI. It's not just your clinical findings. You need to both to marry to make sense. And that's when we will do surgery. And that's why I can tell you our results at Rothman are predictable. I can tell you if you're going to get better and the likelihood of you getting better with surgery. And if I tell you don't have an operation, it's because I think the symptoms you have doesn't mean you don't have pain, but the symptoms you have are unlikely to improve. And so this is just us in the operating room, me operating with my assistant, doing this minimally invasive lateral fusion. You can't even see the incisions. The incisions are pretty small. Okay, so another reason where I see a lot of people is for scoliotic curves. So God designed us with curves in our thoracic spine going one way, our lumbar spine going the other, and the whole purpose is to keep our head above our butt. And so what can happen is you can lose that normal alignment of the spine. So that starts to make you kind of lean forward, and you got to walk kind of hunched over. And so the way that you compensate is by flipping your pelvis backwards and walking like that. And it's hard to maintain your gait like that. So there are circumstances in which people develop arthritis and they lose the normal curves in their back. And we would consider doing an operation to help them stand upright and to remove pressure from the nerves. This is an example of a gentleman who came in with severe arthritis. So you see this curve in the front of his spine. But what's more concerning is this picture here. From the side, his spine is straight. He's lost his normal curvature in his back. And so that makes it very difficult for him to stand upright. He's walking like this. He also had severe leg pain. So he had severe stenosis. His nerves in his back were compressed very, very severely. So he can't stand upright. He can't walk due to pain in his legs. And so he had this pretty big operation in which I had to place screws in his thoracic spine all the way down to his butt. So you think about the gamut of the surgeries that I do, from small microdiscectomies to very big operations. That's why everyone gets an individualized approach. There's no cookie cutter solution. You need to be evaluated. Your circumstance needs to be taken into consideration. What's your health status? How functional you are? I can tell you for sure this operation is not for everybody. And there are many, many people that I would say, do not have a surgery of this magnitude. This is not the right thing for you. But there are some folks that do need something like this. And so I think that's the beauty of our practice, is that we have surgeons that can really do the full gamut of the treatment. But just because we can do this doesn't mean it will be recommended to you. And in order for us to recommend any surgery, it has to make sense. It has to make sense for your situation. And I can tell you myself, I need to be convinced that I can make you better. And if I don't think the operation can make you better, I would not recommend an operation for you. Sacroiliac joint's another thing that can cause pain. So the SI joint is the joint that connects the pelvis to the spine, and that can cause pain into the buttock. And so a lot of people come in with buttock pain and they have SI joint dysfunction. This is typically treated with targeted injections and physical therapy. For people that have refractory pain, they get an injection, their pain goes away, it returns. We can do percutaneous SI joint fusions. These are not big procedures at all, maybe 20 minutes. But again, they're only done in people who have focal SI joint pain in their buttock. They get injections that take away their pain, but the pain comes back. Then those are folks that we may consider doing SI joint fusions on. But the vast majority of these people can be treated with injections and physical therapy. And so this is just an example of a percutaneous SI joint fusion, what it looks like. It's a small incision, and you put some screws across the joint. That stabilizes the joint, and that can help with buttock pain. So reasons we do back surgery: get pain down your leg. So a lot of people come in with numbness in their feet. Numbness in their feet is multifactorial. It's typically from neuropathy. Neuropathy most frequently occurs in people who are diabetic, but numbness in your feet is typically a peripheral nerve problem. If you have an issue in your back and a nerve is compressed, that will cause pain in a dermatomal distribution. Dermatomal, just a fancy word meaning that each nerve in your back supplies a specific portion of your leg. And so if you have a pinched nerve, L3, anterior thigh, L4, lateral thigh to the front of your knee to your shin, L5 is the side of your leg, S1 is your butt, back of your thigh, your calf, lateral border of your foot. Numbness in the feet is typically peripheral neuropathy. But I see a lot of people that come in and say, Doc, I can't feel my feet. Most of them have peripheral neuropathy. If you have weakness in your legs can be from spinal cord compression, but it can also be from nerve root compression in your back. So if you have weakness, I think that's a good reason to be evaluated for surgery. So what I was telling you earlier is that we can do a lot of these surgeries minimally invasively now. When I was learning to do these, we had to do much more soft tissue dissection, and now most of the surgeries I'm doing now are minimally invasive through smaller incisions. The whole purpose of this is to less recovery time, less disruption of the soft tissues, early mobilization, being able to get you up and getting you moving quicker. So this is certainly an advancement. Some of this stuff you got to be careful with. Some of this stuff is gimmicky. What do I mean? Laser spine. Things like laser spine and some of these minimally invasive things that are being proposed, they're not all good. And some of them are hocus pocus. The surgical principles are the same if it's minimally invasive or not. The principles of spinal surgery are to remove pressure from nerves, to provide stability to the spinal column if that is required. Not all the time you have to provide stability. Microdiscectomy is an example where you can just remove pressure. If you have a slippage or translation, that's when stability is required. But there are good minimally invasive options for surgery. But you got to be careful because minimally invasive is marketed a lot, and some of it is hocus pocus. This is just a fancy chart to illustrate some of the improvements we've done with pain management. Most of the operations that I do, folks are off pain medication within the first week. And one of the reasons is that we have a multimodal analgesic protocol in which during the operation and after the operation, we have developed a regimen of medications that will decrease the perioperative pain. That allows you to get up, get moving a lot quicker, and have less requirement of opioids. The reality is most people that have pain, a lot of pain after surgery, are folks that were taking pain medication before surgery. And so if you're taking a lot of pain medication before an operation, you're more likely than not going to need pain medication after surgery. But most people who are not taking pain medication before surgery, the vast majority are off the pain medication within the first weeks after the procedure. And one of the reasons that we're able to do that is through this analgesic protocol, which we developed, in which we give you a certain series of medications before, during, and after surgery, which decreases the pain in the short-term period. Now, I'm not going to sit here and tell you that you won't have any pain if you have an operation in your back, because that's disingenuous and not true. Depending on the type of surgery you have, you will have some discomfort. It is a recovery, but typically it is pretty manageable, and people can mobilize and get moving a lot quicker, which facilitates faster recovery. Another thing that has been an advancement is that we just don't lose much blood anymore. So this is a study that I did when I was at University of Pittsburgh. But what we found is that people who lost a lot of blood in surgery and required blood transfusions from blood that was not theirs, it increased their infection rates. And so we had to develop ways to do these surgeries with less blood loss. And so there's some medications we can give. There's some tools we can use in surgery. One of the big things that we do now is I use what's called a cell saver device. So any blood that you lose in surgery is recycled and given back to you. And minimally invasive surgery where you just don't have to dissect too much of the tissue, so that decreases the blood loss. I can't remember the last time I had to give somebody a blood transfusion that wasn't a trauma case or wasn't a big deformity surgery. So the vast majority of people, 90+%, do not require blood transfusions just because we're better at surgery now. And we can do it minimally invasively. We recycle your blood. So this is an advancement in spinal surgery, because getting allogenic blood or blood transfusions can increase problems with your healing and with your recovery. This is my beautiful family. I'm in the hospital right now because if I would have been home, there's no way we would have got through this talk because my sons would have been bouncing off the walls behind us. So I hope this was informative and it provided some information. I think it's important to have a general idea of what's going on with your body, so you can make informed decisions. I think that if you have any of these symptoms, we're happy to evaluate you. And I can assure you that we will give you an honest assessment. Sometimes that's surgery, sometimes that's not. But there are some things that surgery does very well at treating. And if we recommend an operation for you, it's because we believe it's in your best interest. So hopefully this was informative. And if anyone has any questions, I'm happy to try to address.
Thank you, Dr. Woods. That was amazing. Always learning something from you for sure. So we have a few questions coming in. We will get to as many as we can, considering the hour. So what is the best way to address neurogenic claudication caused by spinal stenosis with significant deterioration at L4 and L5 and significant numbing, pins and needles, and pain in legs and feet?
Well, the first thing is you got to have an MRI. So if you have an MRI and it shows severe nerve compression at L4, 5, and you have those symptoms, then at that point I would consider an operation. If you have an MRI that shows that you might have degeneration but not nerve compression, if you have degeneration but the absence of nerve compression at those levels, then typically we get an EMG or a nerve conduction study to confirm that you have damage or disruption of nerves in your back. If that's the case, then spinal cord stimulators or can be, that's an option. Oftentimes people may have vascular claudication, so that's something that also would need to be ruled out. If you didn't have stenosis in your back, you have degeneration but not compression, you get blood flow studies as well to make sure that you have adequate blood flow to your legs. So it sounds like you need to have an evaluation.
Thank you, Dr. Woods. I have pain in rear right leg from buttocks down. I have 2 epidural shots that work but limited time. Considering alternative to continue shots.
Say that again now. Pain in the buttock, right leg.
Right leg. I have 2 epidural shots that work but limited time only. Considering alternative to continuing shots.
Well, you need an MRI. An MRI needs to be obtained to see if you have nerve compression. If you have nerve compression on the right side, it sounds like if it's your butt and back of your thighs, either your L5 or S1 nerve root. So if you have compression of your L5, S1 nerve root and you're having persistent symptoms, then that's when you get a surgical evaluation to consider an operation to decompress that nerve. If you do not have nerve impingement, then that's a different discussion. But your evaluation starts with an MRI. So that's what I would recommend next for you is a new MRI of your back and then be evaluated.
Okay, thank you. If you have degenerative disc disease and have cages placed, is it likely that other discs will compress and I will need further surgery?
That can happen in your neck or your back. If your bones are fused together, you can develop what's called adjacent segment degeneration. So that's arthritis developing above or below. That happens in about 20% of people. And so it certainly does happen. 2 out of 10 people it happens to. What we advise folks is for strengthening the muscles that support your neck, your back, decreases the likelihood of that happening, but it certainly can happen. And if it does, it would present with new leg pain or weakness. And so if you start to develop those things, you should be reevaluated.
Okay, thank you. How long do patients typically get relief from the ablation procedure?
That's a question for pain management doctors. I would tell you I don't do the ablation procedures. I would tell you it's quite variable. Some people get complete relief of their pain. Some people might get no relief or minimal relief. But most folks, if they get a targeted facet injection and they get improvement with the facet injection, then usually the radiofrequency ablation is pretty helpful.
Thank you. I can't say that word. Oh gosh. If you have can you say it, Dr. Woods? You see the question?
I can't see the big question. Radiofrequency ablation. Where's this in Q&A?
Yeah, Q&A, just click on it, anonymous attendee. I apologize for that. I don't want to butcher the word.
Oh, rhizotomy? Is that what you're talking about?
Down the leg due
It's-
to lumbar disc herniation can be adequately managed with epidural steroid injections repeated over time. Does it make sense to put off surgery as long as possible? Do you see that one?
Okay, I'm trying to find that question. I don't see it.
Scroll
Let's see here.
down midway.
Is that, let's see
Anonymous
here.
attendee 649.
649. Okay, we're getting there. Okay. If radiculopathy down the leg due to lumbar disc herniation can be adequately managed with epidural steroid injections repeated over time. Yes. Yes. So the question was, person has disc herniation and has radiculopathy or leg pain, and they're getting injections and it's helping them, but they got to get a series of injections over time. The reason to change course would be you can typically only get 3 or 4 injections a year. So if you can manage with 3 or 4 injections in a year and you're not getting any weakness in your leg, then there's no problem with continuing with the injections. The concern or what would make you change course is if you're getting the injections and the frequency that you require the injections is increasing. So if you get the injection and it takes your pain away for 2 weeks, you can't get an injection every 2 weeks. So that would be an indication to get evaluated for surgery, or if you start developing weakness in your leg. But I got plenty of people. My wife does these injections that she's been doing injections, a couple injections on folks for years. They come in, they get every 3, 4 months, they get an injection and they go back to their lives. So in the absence of, the pain in the leg happening more frequently or weakness, you can definitely continue with the injections.
Can issues in the neck affect the nerve to the throat, causing difficulty in swallowing? It's a different question.
No, no, the swallowing is not going to be affected by any nerve impingement. But what can happen is if you have an operation on your neck, when we go into the front of the neck to address the disc, it's very common to have difficulty swallowing after those procedures. It's called anterior cervical discectomy and fusion, and you have to move things to the side to get to the front of the neck. So the most common problem people have is difficulty swallowing. That is typically a transient problem, meaning it comes and goes. But nerve impingement in your neck won't cause swallowing issues, but surgery to your neck can cause some problems with swallowing.
Okay, thank you. Do you do the mild procedure and does it help spinal stenosis?
The MAL procedure is done by pain management doctors. It is essentially a procedure where they do an epidural injection and they remove some of the ligament in the back. So that is done by pain management doctors. That is it's much smaller of a procedure than what I would do. What I do is called a laminectomy or microdiscectomy, where I actually visibly remove the pressure from your spinal cord and nerves. I've seen some people get improvement with the MAL procedure. Essentially, it's like an epidural injection. And so I don't have any objections to people that have stenosis trying the MAL procedure, as long as they're not having any substantial or progressive weakness in their legs. So I've seen people who had the MAL procedure and then they got a little bit of relief for a period of time, then the symptoms returned, and then they ultimately came to me. So I don't have a problem with folks trying that, but it's different than the procedure that I do, which is a direct decompression where you actually visibly remove the pressure from the nerves in the back.
Okay, well, considering everyone's time, Dr. Woods, we just want to thank you for all this amazing knowledge. I hope everyone is going to take something away with it and answer some of your questions. If we did not get to your questions, feel free to email me. You also have it in your emails already because of the lecture. And then I'll get those questions over to Dr. Woods. But we thank you so much for joining us, Dr. Woods. Thank you again for your time. And especially since you're in the hospital, we appreciate it. And just great information. Thank you so much.
Great night.